Top Bed Talk.
Good afternoon and welcome back to the final session of EBPOM Ireland 2022, live from the wild west coast of Ireland here in Dingle in the Skelligs Hotel, which is going to be quite interesting. It's a pre-recorded lecture which will make sense in a moment, then mainly a conversation about this, to some of us, not me personally, but to some of us, challenging discussion about non-physician anaesthesia providers in the future. I hope you can see the first slide I put up here, which is NHS workforce shortages and burnout are taking a toll. We had a great session about burnout earlier today, and it's been a recurring theme in this and many meetings. Another recurring theme is there seem to be global shortages of clinicians, of practitioners, of people who are prepared to work in a healthcare environment. And particularly in our very well-resourced worlds, we're now seeing what's referred to, and we heard the term earlier on today, the mass retirement. In other words, despite there being still massive queues of people who are trying to get into medicine in the broadest sense, whether it be nurses or physios, other practitioners, doctors, we seem to have a lot of people who are trying to get out more quickly now. And at a time when it's very difficult, because in the wake of COVID in the United Kingdom, for example, we have record highs in the number of people who are on waiting lists. And I was lucky enough to be relatively recently at a forum in the United States of America where one of the surgeons-in-chief of a very well-known healthcare system reflected on the fact that for the first time in his long and prestigious career, almost everyone has waiting lists now in the United States of America, something that was thought to be a problem that other people have, but now it seems to be another global challenge. And as part of recognising these workforce challenges, the Royal College of Anesthetists did an evaluation of the state of play in the United Kingdom. So this report from February 2022, which is available online at the site, you can find there, the Anaesthetic Workforce UK State of the Nation report. They say that even right at the moment of anaesthesia providers in the United Kingdom, we have a substantial shortfall of people right here and now, such that it will contribute another 1 million surgical procedures to the already large backlog of surgical procedures, unless we can find out something else to do in the short term. Even if we had the money, even if we had the beds, even if we had everything else lined up, we don't have the people to do the work. And projecting forward, by 2040, we'll be short by 25,500 anaesthetists. Now, to put it in context, I'm sure many of you know, when we say anaesthetists in the UK, as it stands currently, for the vast majority of providers have traditionally been physician anaesthesia providers. We, until relatively recently, had resisted, I think is a fair way of expressing it, the idea that other people could give anaesthetics. So the shortfall is going to be massive. So the College of Anesthetists has had a rethink, and we're going to show, I think, a short clip given by Professor William Harrop Griffiths, who's Vice President of the Royal College of Anesthetists, that he presented at EBPOM in London this year, explaining where they've got to in the journey, and then we'll spend the end of this meeting just in a conversation about what we think about that, and we have representation from around the world to contribute. So if we could play the video, please. Thank you.
So now I want you to think solutions to the shortage. Okay, there you are. You're in charge of policy for the National Health Service, and you've got to solve this workforce crisis in NHS. Lots of other specialities have workforce crises as well, but for obvious reasons, I'm going to focus on this one. Hold on to the older anaesthetists that we have. There is a big drive from the NHS, and I've been involved in some of their work. How can we stop 60-year-olds retiring? If I were a cynical man, and let me assure you that I'm not a cynical man, if I were a cynical man, I would say that what you do is steadily degrade the pension until you'll bloody well have to carry on working beyond the age of 60, because you won't be able to afford to buy food if you don't. But I wouldn't say that, and I would not want that sort of sentiment ascribed to me. Throw money at it? Do you know what? We ask people what's important to them. We've asked anaesthetists what's important to them. It's not money. Money's in there, but it's not the top, second or third of the list. We actually like nice working conditions. We like a flexible job plan. So what happens too much in this country is that the 59 3/4-year-old goes up to their clinical leader and said, I'm hitting 60 in 3 months' time. I'd really like to get rid of this on-call stuff. And then the clinical leader says, we have no use for a consultant who's not on call, thank you very much, you can retire. Which is crazy, because you lose that person. Not only are they very experienced, but they tend to be quite quick as well. They might be messy, but they're quite quick in the operating theatre, and they get through cases. You don't want to lose that. So the NHS genuinely is trying to say to trusts, be more flexible, provide good working conditions, accept the fact that that person is ageing and change their job plan. And maybe a little bit of more money, but it's not the money that's going to make the difference. Get retired anaesthetists to come back to work. This is fantastic. One of the senior NHS people was a surgeon, was in fact a colorectal surgeon. And during the height of the pandemic at a meeting, this person, they said, fantastic, we found 245 retired anaesthetists who are prepared to come back to work. And I said, you do realise that that's less than 1% of the workforce? He said, really? Sounded like a big number to me. Well, it's a lot of colorectal surgeons, but it's not actually a lot of anaesthetists. But we can make them come back to work. I said, well, the problem is not many people want to come back to work after 2 years away from anaesthesia. It's not that sort of job. If you're a dermatologist, no, I won't knock dermatologists, that would be very unfair. But rashes don't change very much, do they? The treatment doesn't change. It's all coal tar or steroids. It's nothing else. Where was I? I get my thread back again. You can't take a cardiac anaesthetist who's been out of it for 2 years and say, come back and do a whole week cardiac. You can't make them go back to those things. You've got to give them different things to do. The other problem is anaesthetists retire to Hampshire and Dorset and Cornwall, which is not where the population centres are. And who's going to come back from their thatched cottage in Cornwall and work in a large central England conurbation that I won't mention because it'll offend some of the... It's difficult getting retired people back. This was another great one. The GIRF leader, whose name I mentioned, at one point said, well, I think I've got the solution. Get other people to give the anaesthetics. I mean, how hard can it be? This was after he had seen anaesthetists become amateur intensivists after about a week's update, and he thought, we can do that for anaesthesia. It's much simpler than intensive care. And of course he was shouted down, and I ridiculed him and continue to ridicule him, but there's something there, isn't there? You can't completely dismiss that. Is it imaginable that with the correct amount of training you could have people who'd be trained for a shorter time and are cheaper to give some of the simpler things? Is our workforce model too rigid? Roll back 40 years. This is my view of what the workforce model was 40 years ago. Basically, there are doctor things, there are nurse things, and there are ODA things, probably department assistant for any of you as old as I am. And these are very, very different things. You can't cross the barriers, you can't cross the boundaries, and actually giving a general anaesthetic is definitely a doctor thing, and that's basically our workforce model. So roll forward 20 years, and the now luxuriously mustachioed Harriet Griffiths achieves election to the Council of the Association of Anaesthetists, and one of the things we were discussing was exactly this. But even then, the workforce model was as follows. There are doctor things, there are nurse things, there are now ODP things, and they go very different things, and giving an anaesthetic is definitely a doctor thing, or almost always a doctor thing, and that's about it. So that we would just start to talk about anaesthetic practitioners 20 years ago when I joined the Council of the Association of Anaesthetists. Things are changing in 2022. And we say, well, actually, there might just be a few sort of different ways of doing this. Why divide clinical activities into doctor things, nurse things, ODP things, and non-doctor, non-nurse, not ODP things, when actually, if there's a thing to do, what you need is the person with the knowledge, skills, experience, capability, and whatever attributes in order to do the thing. And it doesn't matter at all whether they're called doctor or nurse or ODP. The titles actually mean nothing to the safety and efficacy of the procedure, and probably not a great deal to the patient either. So what I will argue to you is that I think now is the time to question the traditional and rigid workforce model. We're looking at changes happening right across medicine at the moment. Things are moving. We are seeing the growth and emergence of medical associate professions. You may already have worked with physician associates, with advanced critical care practitioners, with surgical care practitioners, and now with the main point of my talk, which is anaesthesia associates. There are very many of these MAPs overall. But if you take it and you say, what do the key stakeholders in this process, what do they really want? What do they actually want? What do the patients want? What do anaesthetists want? And what does the NHS want? There are lots of other stakeholders as well. What do they want? Well, I would argue that patients want their anaesthesia services delivered safely by competent and knowledgeable people. You are welcome to stand up and say, oi, They want doctors to give them their anaesthetics. But you and I know that most patients are blithely unaware of whether we're doctors or not. That's probably our fault for not informing them, or the surgeon's fault for not telling them. They shouldn't really mind what the title of the person is, as long as they're competent to do it. This is what anaesthetists want. I've just mentioned this. This is not just old anaesthetists want, but even younger anaesthetists and even young anaesthetists want this as well. We want good working conditions. We want flexible job plans when we need flexible job plans. We want some sort of recognition. We want people to understand what we do, why we do it, and to say well done when we actually do it right, which is precious little of in the NHS at the moment. And at the end, we want a decent reward for the work that we put in and for the training that we've had. What does the NHS want? The NHS wants an abundant supply of good value, competent anaesthesia providers, because it just does, okay? Because it's looking at the bottom line, the money. And that's what it wants them to be good, and it wants lots of them, and it wants them to provide anaesthesia. Now, back in the day, the trainees were abundant. There were loads of us, and each stage of our career, there were fewer. It was like a pyramid. People dropped out at the end of SHO, registrar and senior registrar, because of the pyramidal structure of training, because we're kind of disposable. You know, if you couldn't get on, you couldn't get on. It's a tough life. Go and do another speciality. We were good value because we were paid naff all. I got £9,000 for a year as an SHO, and even taking inflation into account, that's only about 30 grand these days. We were relatively underpaid. And we were competent because we worked endless hours. Because we were always at the hospital, always giving anaesthetics. We became very quickly very competent. And it was fantastic. We could do all these cases. The consultants barely had to turn up. And in St Thomas's Hospital in those days, they didn't turn up. They were busy elsewhere. Then this guy happened to us, Sir Kenneth Calman, and he said some really radical things. He said, don't abuse trainees, train them. What? And have run-through training so you don't get wastage of people who've put half their professional life into something and then get spat out by the system. Don't overwork them. What? This was incredible. But he was right, and so we had Calmanisation. There's a problem that all of a sudden these abundant, dirt cheap, competent trainees were changing subtly, not to be as any of the three of them are taking longer to train. So now we've got consultants. Sarah doesn't know she's being shown, but she is an absolute example of fantastic competence. The consultants are competent, brilliantly competent. We turn out wonderful consultants. They're not terribly good value because they're at the top of the tree when it comes to medical pay, so they do cost quite a lot. And as I've just hopefully pointed out, they're not terribly abundant either. Pay scales, I'll let you feast your eyes on those pay scales for a few seconds. Trainee pay scale is the hardest because there's lots of factors that affect how much they get, and some may get more than that, not many are going to get less than that. And if there are any trainees who are looking at that and saying, you're completely wrong, tell me at the end and I'll change that slide. At the bottom is anaesthesia associate, and what draws the eye to start off with, and they're on band 7 or 8A of Agenda for Change, is that there's quite a lot of overlap between anaesthesia associate, trainee and SAS. And there is quite a lot of overlap, and that causes quite a lot of disquiet. People say it's an awful lot of money. But band 7 and band 8A of Agenda for Change is where they settle. But consultants right at the top, and that's before they get any sort of local clinical excellence awards, national clinical impact awards, additional management payments or anything like that. But you've also got to remember that although the thing you are instantly have your eye drawn towards is the person's salary, the cost to the NHS is not just salary. Anaesthetists need training, and consultants take an awful long time to train. We are 5 years at medical school, 2 foundation years, 3 core training years, 4 specialist training years. That's 14 years as a minimum. From when I first stepped foot into Oxford University Medical School to when I actually became a substantive consultant anaesthetist was 16 years. And in those days that was considered really rather quick. Or he's sure he's grown up in. It is a very long time even now it takes, at least. So SAS doctors, pretty long time as well, 5 years at medical school, 2 years foundation training, and then at least 4 years postgraduate training after that, which is quite a few years as well. Let's turn now to anaesthesia associates. We hope that most of the anaesthesia associates will come from science degree backgrounds, okay? We don't want to deplete too many of the ODPs, anaesthetic nurses and other people already employed by the NHS. The great news is that we don't have to pay for the science degree. That's all done by somebody else. The NHS doesn't pay for it. What we pay for, effectively, is a 2 years, 3-month master's course, which means that the amount of time it takes to turn somebody into an anaesthesia associate is 2 years, 3 months. I am not saying that there is an equivalence between a consultant anaesthetist, an SAS doctor, and an anaesthesia associate at the end of training. There are huge differences in knowledge, skills, experience, capability. But if you can produce part of the workforce that can help you with a large proportion of those people waiting who are ASA 1 or 2, who are undergoing minor or intermediate procedures, is it not wise not to use the most expensive people that you employ, but some of the less expensive people that you employ? It makes, to my mind, fundamental sense. So I think now is a time for a bigger workforce, and I'm going to use the B word, now is time for a blended workforce, which just means a bit more varied, chucking another couple of groups of people into it. But blended is a really good word because it sounds cool. Blended teaching, it's really popular at the moment. In which this workforce, you match the tasks to the capability. You don't overplay the capability to the task. You make sure that they've got the capability for the task, that there is appropriate supervision and backup, but that you don't overqualify people to do When I took my pension in 2019, I was the best paid consultant in the anaesthetic department. I did mostly gynae lists. It doesn't make financial sense. I loved it, don't get me wrong. It's fantastic, very relaxing and good fun, nice for the patients, nice people to work with. But financially, that doesn't make any sense at all. Patient safety in this context would be supported by supervision. Do not think, if you're a trainee, that your chances of being employed at the end are in any way going to be affected by the growth of anaesthesia associates in the next few years, because there's room for more of everything. More consultants, more SAS doctors, more trainees, more anaesthesia associates, because we are so short of anaesthesia providers in the UK. That gives you greater capacity, gives you greater flexibility. In theory, it gives you greater efficiency, and in theory, and I accept in theory, every bit as safe, providing we do it absolutely right. I don't need to tell you that anaesthetists don't just give anaesthetics, and up on their screen now is a few of the other things that we do. And I'm going to call your attention just to 2 of them: sedation and transfer. A lot of patients get sedated in dangerous circumstances by people who are not trained properly to rescue from the consequences of moderate and deep sedation. Down in the X-ray department, down in the cardiology department, deep down in the bowels of the endoscopy department. Meanwhile, a lot of people who receive sedation in the operating theatre receive sedation from people who've been in the business for 40 years when they don't need to. There's a disparity and a mismatch in the provision of capability for a lot of people undergoing sedation. And it's true for transfer as well. You know yourself, if you work in an anaesthetic department, that the only person available to take the transfer to the hospital 30 miles away is the ST6 that you desperately need, when the only reason you're sending the ST6 is because the physicians are too frightened, the patient's not intubated. You just have to sit there for an etc., 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 etc. You could have somebody trained in transfer who could, if necessary, control and maintain that airway if needs be, but isn't the highly valuable, highly trained ST6 or consultant anaesthetist.
The presentation was deliberately cut off at that stage because the next bit, which you can watch online from EBPOM London, was the what's next bit, which we can come back to in a second. But the purpose of this discussion here is to get some thoughts and views from the floor, and we have an interesting spectrum of countries represented in the room that have had different experiences in travelling this journey. Now, I'm going to ask one of my colleagues from the UK, who's been involved in training in anaesthesia, to make an initial comment. I don't know how advanced you are in understanding where the college is going on this, but I'm going to ask you to make that. And I also want to point out that Mike Grocott is an immediate past Vice President of the Royal College of Anesthetists, who has some additional knowledge about the discussions that have been taking place. So just to get things going, and then if people are going to start to call in people from different countries and different perspectives.
Thanks, Monty. I'm Ollie Pratt. I'm a TPD in the Northwest, Training Programme Director for Core Anaesthesia Training. I've previously had some peripheral roles with the College of Anesthetists in training roles. But I also work in Salford, where we've had anaesthesia associates for some years. I'm not up to date with the college's current thinking on exactly where we are with AA, so I don't think I can really comment too much on the current college line on AAs.
But what's your personal...
Having had experience of working with AAs for a number of years, we find them in our department to be very valuable members of the team. I don't think we have always perhaps used our AAs to their full potential in our department, but I think that's changing, and we're increasingly extending the scope of practice of our AAs. So we now have AAs who are able to run block lists. One of our AAs is probably one of the best regional anaesthesia practitioners in the department. We are starting to do some 2-to-1 working with simple ASA 1-day case patients. So that's one consultant supervising 2 AAs running lists. And we've started, AAs have been running or are starting to run sedation lists, and also we're allowing them to do cardioversion lists all as a remotely supervised list. So we're increasing the roles that the AAs are able to fulfill. I think the main thing that we have done for a lot of years is allow the AAs to facilitate day of surgery admission. So we have staggered admissions throughout the days. Most of our lists in our department will be 3-session lists, so we'll be trying to run the theatre for 11.5 hours or so, and to allow the patients to come in at staggered times throughout the day. When we work with an anaesthesia associate, that makes things a lot easier for us. And it also makes your working day nicer if you work with an anaesthesia associate, because it's, sharing the workload.
So I'm hearing overall positivity here.
Yeah.
I think you think it's part of the solution, part of the future. I'm
Yeah,
just going to put the litmus paper in the water now and ask Craig.
Craig Goldsack from University College London. We've had PAAs for a dozen or so years. They've all come through an ODP or anaesthetic nurse background, and I was involved in my brief foray into medical management when we started the programme. Went up to getting back to Ollie's point about blocks, Birmingham have a massive upper limb regional trauma centre, and they were using their PAAs to do blocks kind of in sequence with supervision from a senior or consultant anaesthetist. Our own hospital doesn't have that level of regional workload, but we do use for a lot of sedation work, and actually increasingly with the more fragmented or disjointed training, that's not meant to sound pejorative, of our trainees, they actually provide a certain amount of continuity of service. We start off with 3, now 6, and I think we're just training up another half a dozen, so we'll have about 12 in a couple of years' time. They have sedation, some role in assisting with minor cases and regional blocks, and we've got a sort of fairly rigorous supervision stroke ownership, so they're all notionally supervised by a senior anaesthetist during the day, and they're reliable, they work in the daytime, and then there's a continuity of them being around, and I work next to one of them on a Wednesday. He does a sedation for some urology patients, and I'm next door doing my list, but keeping an eye on him. So I went from being resistant, sort of small c conservative, thinking in a way it was going to impact on training really for our trainees, but in fact they're parallel. There's enough work, as William Harrop Griffiths was saying, for everybody. They're a self-selecting group of motivated individuals who've achieved a certain level in whichever bit of nursing or ODP they were doing, and they want to challenge themselves and do something better. And our programme, it's hard work for them because they're in full-time education again, they're not earning very much. They want to do it because they're motivated, and they come out the other end, and it's good working with them. I get a bit frustrated if I'm with one and I go away and see another patient and I say, don't touch anything, and I come back and it's all over the place, but that's just me being a bit grumpy. So yeah, I've gone from being resistant to positive, yeah. And I'm thinking when I retire, maybe next year, I'll take my pension and come back as a PAA.
John, now, in William Harrop Griffiths' talk, he talked for a short period of time about the United States of America. He'd spent some time over there in the past doing a sort of senior fellowship, junior attending type of role. Many of us have worked in the States. We've seen the strengths and weaknesses of the shared cared model. I've seen it work really, really well, but we see quite a lot on the Twitter sphere, social media, about what appears to be some sort of pitch battle between CRNAs and physician anaesthesia providers. And he referred to the fact that whatever happens, we really don't want to let that happen. You know, everyone's there for the patient. How do we get this right? Have you got any thoughts on that?
Sure. I do have that, and I've had experience both working at academics at the University of Pittsburgh and the Medical College of Georgia, and also in private practice as well too. To initiate this, to the west of the Mississippi, it is usually physician-administered anesthesia in the United States at this time. East of the Mississippi, it is a care team model. And when I was at the University of Pittsburgh, anesthesia residents and certified registered nurse anesthetists work together in delivering care. So we learned a care team model. Of course, at one time it was medical direction, and that was dictated that it was a 1-to-4 model. But then we start, again, losing nurse anesthetists for a couple of reasons. Many resigned during COVID, and now there has been increased education demands by some of the nurse anesthesia schools where they're going 3 years to get their doctorate. So that is reducing the number of providers. So a new specialty, anesthesia assistants, has come in. Nurse anesthetists normally, and this is generally speaking, need to be trained in either the MICU, surgical ICU, or the ER, so they have experience. AAs come right out of college, or many of them are respiratory therapists. So they have to be up-trained in terms of dealing with pharmacologic distribution, pumps, etc. As long as the provider is dedicated and want to learn, my job in being an administrator and a chairman of a department is to give them the appropriate education to upskill them. And my last academic stay, which was at the Medical College of Georgia, I found there was AAs, residents, and CRNAs, and quite frankly, I couldn't tell the difference between the AAs and the CRNAs. As long as they wanted to train, they did an equal job. So from my perspective, there is a rift right now. CRNAs believe they are more highly trained than AAs. Many CRNAs do not want to work with AAs. So when we are hiring, we really have to balance that perspective of whether you're going to have a mixed staff or it's going to be and just AAs, or whether it's going to be CRNAs. In the 15 hospitals that I work with in the West Florida, we have CRNAs in residence. We have a few practices that are AAs alone, and the rest of them are CRNAs alone. We don't have any mixed staff, but that's not everywhere.
I think what I took from William's presentation and the discussions when I was on College Council is the reason they chose not to go down the CRNA route was two major reasons. One was we want our wonderful nurses to carry on nursing. We have a shortfall of nurses as well, so we didn't want to immediately deplete that pool. And we also, from everyone advised us, don't create a situation where you're going to get into turf wars, because it's really not helpful. Ross, what do you think about what you're hearing from the Australian perspective, from your global perspective?
It's not being looked at in Australia as far as I know. It has in the past, and I think the powers that be have got the message that this is not a battle worth taking on.
Does it have to be a battle, though? Who's fighting who?
Certainly in New Zealand, at one stage, the government was pushing a non-medical anaesthesia provider experiment, but they've backed away from it.
Because of lack of supply, or as a way of trying to cost contain?
I think in general there's not a overwhelming problem of lack of supply. Certainly in the medical workforce as it stands, the areas where there's prospects of major lack of supply, psychiatry, general practice, they're the two big ones that spring to mind. So it hasn't been an issue. From the conversation, I think the nurse issue, I think absolutely. I mean, for as much as we might be short of doctors, a shortage of nurses is more of a problem. And you could ask, why are we employing nurses in the operating theatres in scrub roles? That would be one thing that, why do you need nursing training to do that? But, so I think that's a smart thing. But again, I mean, from what I've heard in Britain, I hear that AAs have been working in niche roles, but if you're talking in big numbers, how are you going to train them up to really amplify the workload potential of the medical anaesthetist? And I think that's going to be a real
Great,
problem.
so we'll put that on the list for Mike to speak a little bit too in a few minutes. We've got another voice coming in. Thanks, Ross. Another voice coming in from the back.
I'm May O'Sullivan and I'm an anaesthetic trainee in Ireland, and these roles aren't really ones that I've experienced over here. So just in terms of the practicalities of it, I have a few questions just for people who have a lot more experience than me. The first is in terms of ratios of consultant to AAs or CRNAs, how many anaesthetic trainees get the 1:4 ratio that you mentioned in the States, or the 1:2 ratio, and does it impact on training for trainees? The second is how many trainees are getting the independence to do those cardioversion lists that AAs are doing? Or do we have a deficit in training of anaesthetic trainees coming through the ranks who need to learn how to deliver safe procedural sedation too without overcooking things. When do they start to replace us? Why do we bother training as hard as we do for as long as we do to establish turf wars similar to those in the States with the CRNA situation? And when do these advanced care providers start replacing people in on-call rotas? You've got people that you've an excellent working relationship, who you really trust, you know that they've got a pretty advanced skill set, but they haven't done their FRCA, or in Ireland their FCAI, in the States I guess their boards. So you've got a lot of experiential learning, but what's the actual depth of knowledge in comparison to people who are filling an alternative role? I feel that it's a little bit of a slippery slope. In the UK, you've got advanced care providers who are stepping up to very senior roles within the emergency department and taking on the senior trainee role overnight. So I'm just wondering if we're opening a little bit of a can of worms.
And do you see an alternative, as we have a predicted shortfall in a period of time where we can't train up doctors, if you sort of mean, to do it? So we have an existing shortfall, we have an impending worsening shortfall, and then we have a massive shortfall. I hear your concerns, which are the ones that I think Mike will help us to address, but if the reality is we don't have enough people, is that a point at which somebody sometimes says, well, maybe we need to approach the edge?
Are you compromising care? Are you compromising current care, and are you compromising future care? And is it worth the wait if the care you're going to get is potentially superior?
Great. Mike, do you want to start dealing with a few of those things?
Sorry, the list was extensive.
The long agenda you've laid out. I'll start picking things off and let's see how we get on.
So in other words, what's the plan?
So if I preface comments in terms of the college's role in this by, so my direct personal experience, which is clinically now exclusively in ICU, is of working alongside ACCPs who work alongside our trainees, advanced critical care practitioners, who are a little bit different in that they are healthcare professionals who've done an additional credential and become, reflecting the other comments, they're often almost indistinguishable from our trainees, and they're absolutely excellent. And I think that that mirrors most people's experience of anaesthesia associates, who are clearly distinct. They're not health professionals taking on a new role. They're graduates who are new individuals coming into the healthcare system, as opposed to shifting roles around within the healthcare system. I don't think I've ever met anybody, like I don't recall meeting anybody who's worked with anaesthesia associates who didn't have positive commentary about that experience. So that has influenced me, and that's obviously increasing the number of people have worked with anaesthesia associates, and the concerns come from those who haven't, which doesn't mean they're wrong, but that's my experience of the conversation. The college, there is a faculty of anaesthesia associates which is being established within the college, which has organisational structures rather like we have a faculty of pain medicine, but obviously this one is bringing in new non-physician anaesthesia providers from outside the college, so it will effectively make the college bigger, and all the structures and elements of that are in place, the membership's established. And I think I'm expressing this sort of college view here, I think that's absolutely the right way to go. The college should encompass all professionals who practice anaesthesia. And again, my American friends and colleagues, this may sit comfortably with them or not, but my impression is that because that's not the case in America, there is a level of conflict between organisations that's maybe not as productive as it might be on occasions. So I think it's the right thing for the college to do. I mean, I think the college has been on the journey from not being particularly enthusiastic about this to learning, and actually is pretty enthusiastic. And I think, it's inevitable. Whether we embrace it or not, I think it's inevitable that non-physician anaesthesia providers will be in the workforce. The workforce predictions for physician anaesthesia providers are absolutely shocking if you've seen them. If you look forward a decade, we're just going to be desperately short of anaesthetists. I'm talking in the thousands, heading towards tens of thousands. And I think the likely direction of travel with anaesthesia associates will be to help plug some of that gap. In the early days, I think it's reasonably prescribed what the role would be, the level of supervision, or the types of activities. Now, expressing a personal view, I can see that will change over time. If you think of sites where it's increasingly hard to provide staff, it's hard to provide staff overnight, you can see the nature of supervision, which may be initially face-to-face and direct, being a little bit more remote, and once it's a little bit remote, it could be even more remote. Will we get to the point where anaesthesia associates are in hospital overnight for simple cases and the consultants are at home and come in to help sometimes? I don't know. If you're doing something at night, it should be we focus on having a consultant-delivered service. But I think some of the manpower challenges are going to be enormous. I think we've done the right thing to embrace it, and my experience is that people who have direct experience seem pretty enthusiastic about anaesthesia associates. But I also hear and understand the concerns of those that don't.
I thought it might be just worth coming back to some of the points that were raised regarding potential conflict between anaesthesia trainees. Again, I come at this as a current TPD and a previous college tutor in the department where we've had, obviously, trainees and anaesthesia associates. And I think in the early days, there was maybe a little bit of conflict. And I think some of that was about the early AAs getting into their role, bedding in, establishing themselves within the department and establishing the role. I think we find now, as we have more experience with the AAs, that actually the AAs are able to contribute to and facilitate training. And I think that works in a couple of ways. I've already implied that one of our best regional anaesthesia practitioners is one of our AAs, and he will teach our registrars how to do blocks. And we are happy for him to teach our registrars how to do blocks because he's better at them than a lot of us are. I think the other thing that it does is often if you are a consultant in a list and you have an AA working with you, it frees your time to be able to contribute in a more direct way towards your trainees' learning objectives. So I think as long as the rotas within the department are organised carefully and with a bit of forethought so that people are getting the appropriate clinical work that they need, then if there's an AA on that list and a trainee, that doesn't necessarily matter because at the beginning, you as the consultant facilitate the discussion, how are we going to do this, who wants to do what's everybody's needs from the list today. And frequently you do find, and particularly with the core trainees, the CT1s, you can find that they learn from the AAs. And as I say, it frees up, the presence of the AA frees up the consultant so that you can have a more hands-on role with the trainee.
Owen O'Sullivan from Cork in Ireland. Just a slightly different note, and Monty maybe alluded a little bit to this yesterday in the discussions at the HPI, and I think you suggested maybe next year you might be discussing the role of technology in essentially directing care in an automated fashion. Like, what is the delivery of anaesthesia going to be like in 20 or 30 years, into the extent that, you know, the cognitive input into, you know, delivering anaesthesia may be more predictable by a piece of technology, and is that the context that this needs to be discussed in as well?
Absolutely. It's definitely on the list of partially threatened specialties from the technological developments. But another way of looking at that is the value of the physician anaesthesia provider goes up, not down, if you see what I mean. But just the work changes. John, and then I'll come back to Craig, and I'll come back to Ross.
A comment about both need and technology. One of the things, at least in the United States, was the amount of gastroenterology procedures that we did, and that was, of course, found having colonoscopies prevented colon cancer, and so it really reduced loss of work and enhanced medical conditions. We tried technology. I don't know if any of you remember, but about 15 years ago, Baxter tried a device that was a hand that the patient would grip, and it would deliver propofol to you, and when you became relaxed, you would go to sleep, release the hand grip, and the propofol wouldn't stop. I remember that was being trialed at a couple of the places, I bet, and it didn't pan out. The next thing that occurred was to have a society of gastroenterology nurses who would deliver propofol because gastroenterologists had one of the highest rate of malpractice because they would tell the nurses to deliver the sedation, and then there was really nobody to rescue them if they had airway issues. So they were going to perform this society of gastroenterology nurses. They trained them how to give propofol, and to get certified, you had to be able to perform 5 intubations to get your license. That failed miserably. So we have tried in a multitude of ways how to expand our services. Actually, I can use my skill directing 4 or 6 people and give the same attention to every single patient, and I can deliver more care, high quality care, to a greater group of people that need it. So it can be done. It is a whole skill learning how to supervise. Mike, you made a comment. somebody comes in and you stay at home. No, the responsibility is your name is on that chart. You have to be there, and you are equally responsible for all of those patients. But what you do is you provide a quality extension of yourself so you can deliver good quality care to a higher number of people. And part of that is I have to be responsible for making sure everybody is trained and educated to the highest level they can be.
It's true in your practice, but I understood one of the drivers for development of CRNAs in the States was environments where physicians were simply unavailable to provide anaesthesia. And I think that same driver, there will be places in the United Kingdom where it's so hard to get a physician anaesthetist that we're asking AAs to do more.
And you're correct. And there is independent practice of CRNAs in some states, such as North Dakota, Montana, South Dakota, where there simply isn't any physicians there. So yes, and many of them are military trained, and so they are used to training in military hospitals by themselves anyway. So those physicians or those nurse anesthetists actually make significantly amount more of money. But what has happened, I think in 2020, the average salary was $167,000. It's around $250 now. So, but that's part of what we're paying for to extend our services.
I think, Mike, you and Monty both ITU guys, really. I gave up ITU years ago, and I have a busy anaesthesia practice with varying degrees of complexity. I think part of the reason we're talking about it rather glibly is that we've made anaesthesia look too easy, and it isn't easy. It's very difficult. We make it look easy. It can be incredibly stressful. So whilst I'm broadly supportive of having PAAs, I don't think they should be taken as being independent practitioners. And as we were discussing, it's got to be a named consultant is responsible. They're very good, as Ollie was alluding to, at being trained to do specialist things in niche areas, and actually are very good at teaching our trainees to do that. I personally think it would be a medico-legal and actually a human disaster if we let PAAs who have not got the training or the experience and often get slightly overconfident and no, not good. Our trainees have gone through, as we were hearing, many years of study. It becomes almost automatic, our understanding of physiology and complex multitasking. And with due respect to any PAAs listening, you can't just do it in a year and think you can do everything. So we use them as parallel. They're good at helping. They don't take over the training experience. If you've got a big, long case on the table, you can leave the PAAs and go off and do something else. But it's not good for having them practicing independently. I certainly would be very, very uncomfortable with it.
So there were two separate things there. The current arrangements and plans are for a very clearly circumscribed supervised role, and that's crystal clear. The other comments are entirely speculative, but I think, so in part built on our experience of ACCPs in critical care. Sure, straight out of 2 years, 3 months of anaesthesia associate training, that's highly unlikely to be appropriate or safe. But what you end up having is practitioners who have done that and then have 25 years of experience in a department. You have a very high level of confidence around particular skills, so Ollie's discussion of their block specialist. And I think over time, the picture will become more complicated under circumstances where there's not enough physicians around. I don't know which way that will play out, but I think if we don't think about these things, we're not going to anticipate them. I think that potentially comes.
Just a couple of things. I'm not sure what the numbers of AAs or PAAs, is it, in Britain are now, but I think it's a bit dangerous if they're only small numbers to say that they're really good, because by definition you're getting people who are the initial pioneers and they're going to be highly motivated. They're self-selected to be exceptional individuals and they're going to really be training at and will perform at a very high level. But if this becomes a big group to change your workforce, then they're not the people that you're going to get. And so probably the standard would fall. And I think what's the problem you're trying to fix? If it's a shortfall or skill shortage in remote and very understaffed locations, then you should address that. If it's the workforce issue that I thought was a problem, then that's what you should be focusing on. And you've got to work out a structure for doing that. And to my mind, if you're going to go down this route, you've got to pursue the American model of having big centres doing a whole lot of scopes or arthroplasties or peripheral orthopaedic surgery or other very well triaged procedures and have a structure where you have, say, 4 theatres with 1 or 2 people circulating between them, staffing them. But you probably do have some centres where you could do that. That may be that you've got to think of saying we've got to set that up at the same time, and that would be in the big urban centres. It's not going to be in the periphery. The other thing, are you going to train people who can go out of the country? Because if they can cross the Atlantic, then you're not really achieving anything. You're just training people to go to Florida and you won't have solved your problems at all.
So I don't think there's any anticipation at the moment that it's a transportable issue. So I think the 2 workforce issues you alluded to are interrelated. So everywhere is challenged, but some places are more challenged than others, and that's the particular characteristics of those hospitals. I think it's a massive opportunity for us. I don't, and I suspect our trainees don't regret the fact that they no longer have to draw blood in the morning, as I remember doing when I started as a house officer, and they no longer have to write the forms, the computer does it for us. And I think some task shifting is entirely appropriate, and it's important that we focus on where our added value is. So putting peripheral venous cannula in completely straightforward cases, if you've got somebody there who can do that for you while you're doing something else, the whole process can be speeded up. I think that there are all sorts of technical roles that an AA could be hugely advantageous for. We need to focus on what differentiates us professionally beyond the technical. I mean, I've heard you talk about this many times, but what makes us professionals also, and I would say this because I'm enthusiastic for both, but I think it drives the importance of both perioperative medicine, perioperative care, and research and innovation within our specialty. So those are part of the professional roles of more and more folk.
Mike, we've got 3 Slido questions. One's just added. I'm sorry we won't have time to get to the 4th. Have we asked the patients what they think?
We have, but only in so much as the lay committee, which is now I think called Anaesthesia Voices of the Royal College of Anesthetists and the Association of Anesthetists, have been involved in this conversation all the way through. So that they are supportive of this direction of travel.
Surely we need to think about the job that needs doing and not the person doing the job, I think, is part of the key message. So I think that's the second statement.
Absolutely.
And probably the most challenging question is, given everything that we've said and the stats that we've shown, are there plans for the college to advocate for a large increase in anaesthetic training numbers to help address the shortfall?
I can reassure you that the college are relentlessly arguing for large increases in anaesthetic training numbers, and actually in the last couple of years have been a little bit more successful. But we are pushing that agenda, but it's...
So if, and we've heard all the concerns in the room and the balance of opinions, if someone somewhere is putting the brakes on that, it would appear that there is a deliberate aim to try and make many more things delivered by people that are conceded to be greater value, which equals lower cost.
I think it's reasonable to say that it's part of health policy in this country and most countries to shift tasks down to the lowest, cheapest level where appropriate, because otherwise you're running your business inefficiently, aren't you?
Yeah. So one thing that I don't know if everyone fully appreciates, one from a distance before you get very much involved with the college has the impression that they decide the number of people who get trained. That is not the case, is it?
No. We can advocate, and we can try and influence, but we do not have control.
That's determined by other people.
Yeah.
So we need to go and talk to the other people as well. Thank you very much for that, folks.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.